cancers. So to start with the introduction, the anaplastic thyroid cancers is the most aggressive form of thyroid carcinoma, and they are the most undifferentiated form of cancers, and they're the most deadliest form of cancers as to pertain to thyroid cancers. And it is responsible for a very less number of thyroid cancers, around 1.7% of all thyroid cancers, while geographically the prevalence ranges from 1.3 to 9.8%. Why this huge variation? Because it has been seen that ATC is more prevalent in areas which are iodine deficient. So ATC originate from thyroid follicle, the same thyroid follicle which can give rise to differentiated form of cancers like as follicular and papillary. The same thyroid follicle after multiple mutation hits can also give rise to anaplastic thyroid cancers. So they are hypothesized to be lesions that have de-differentiated from more benign differentiated follicular neoplasm. So if we talk about the epidemiology, it is primarily a disease of the elderly with female predominance, and the mean age of presentation is around 6 to 7 decades, and women takes a toll over males, and around 55 to 77% of all patients are the female. In several countries, the prevalence of anaplastic thyroid cancer has decreased dramatically due to increased dietary iodine and better management of differentiated thyroid cancers. So in our country also, although data is not very suffice, but after the iodine deficiency disorder control program started in 1962, it has decreased down from 0.4 to 0.6%. And the median survival is very, very, very less. It's around 5 months, and our 20-year survival is 1 year. So
1 year survival is
20%, ma'am. Sorry, ma'am. It's 1 year survival is 20%. So if I tell about the clinico-pathological profile, all the data is from the Western world, but there is one study which is done from our department and in combination with the RML. They tell about the clinico-pathological profile of anaplastic thyroid carcinoma in an area which is endemic goiter like ours, which is a Terai region in the foothills of the Himalayas, which is proven to be iodine deficient area. So in this study, it was seen that...
This was not along with RML.
Okay, ma'am.
This was Roma Pradhan's dissertation,
Okay, ma'am.
which is now she's a consultant in her, but it is a study from SGPGIMS.
Okay, sorry. So in this study, it was a retrospective study audit basically in which 100 patients diagnosed with anaplastic thyroid carcinoma between 1991 and 2013 were reviewed in our college. The mean age of presentation was 58 years, and about 34 patients were less than 50 years of age. And there were around 7 to 8 patients who were also around 40 years of age while presenting with anaplastic thyroid cancer. About 1/3 of the patient presented as a sudden enlargement of the pre-existing goiter over a few weeks, which clearly tells that could be iodine deficiency, which is lead to goiter and can also lead to anaplastic thyroid cancer. The median duration of symptoms before diagnosis was 3 months, and about 41% of the patient presented with lymph node enlargement and 31% with distant mets. So this study was conclusive that ATC in an endemic goiter area presents at an earlier age, and 1/3 of the ATC is due to anaplastic transformation of pre-existing goiter. So how the pathogenesis of this anaplastic thyroid cancer takes place, as I've told you, the same cell, which is a follicular cell of the thyroid gland, which can give rise to follicular, papillary, and Hertel cell. The same cell, when gets a lot of de-differentiation, when it doesn't resemble its parent cell, and there are multiple mutation hit, it can lead to anaplastic thyroid cancer. But there are variably a large number of mutations occurring in the BRAF, RAS, and TP53 gene, which is a cause of anaplastic thyroid cancer and so much of de-differentiation. And ATC can also be arise de novo, which is postulated to be due to mutations in the ERBB pathway genes and the mTOR pathway. So if I talk about briefly about the mutation, so if this is a thyroid follicle, then what happens? There are 2 signaling pathways, and if you want to lead to any cancer, then it's not a particular step, it's multi-step carcinogenesis which is taking place. So there's a thyroid follicle, and there are 2 pathways. One is the MAP kinase pathway, and other is the PI3KCA pathway. So what is the function of the MAP kinase pathway? The MAP kinase pathway leads to cell differentiation, growth, and also the endocrine function of the thyroid gland. So when there is an oncogenic hit in the MAP kinase pathway, then there is a RET transmembrane receptor on the cell, and it gets phosphorylated due to action of various cytokines and ligands. And the moment it gets phosphorylated, it generates signal to the RAS, which is a proto-oncogene, and this proto-oncogene is activated, which leads to mutation in the BRAF gene and leads to papillary carcinoma. Now, the same RAS gene can also activate the PI3-KCA pathway, which is also a mitogenic pathway, helps in cell growth and differentiation. It can also lead to follicular carcinoma. So in this multi-step carcinogenesis, now in next step, if there will be mutation in the TP53 gene, which is a tumor suppressing gene, and it leads to poorly differentiated carcinoma, and if there is more mutation, and in the BRAF gene, if the valine is replaced by glutamine in the 600 position, that's why we call it BRAF V600E, it leads to anaplastic carcinoma. So it is this tells us that it could be fascinating for a scientist to see this pathway, but at the same time, it is very bothersome for a clinician, because the same thyroid follicle which gives rise to a papillary carcinoma, in which the survival is around years, 20 years, 30 years, the same cell can also give rise to anaplastic carcinoma, and the survival is less than 1 year. So moving ahead, how the patient will present to us in the OPD. The tumor is defined as much by its clinical behavior as its histological appearance. So when diagnosed, most anaplastic thyroid carcinomas are widely invasive. They replace most of all the normal appearing gland and freely infiltrates the perithyroidal tissue. So clinical features will be a rapidly visible hard mass in the lower front part of the neck, which we normally see in the patients in the OPD presenting with a large central neck mass. There is difficult or loud breathing due to restricted airway or trachea, because in posterior to the thyroid gland is a trachea, and there is always tracheal compression by the gland, which can also lead to hoarseness. There is difficulty in swallowing, as the esophagus behind trachea can also get involved. And there are pressure and shortness of breath when patients lie down on their back. They always complain that when we try to sleep at night, what happens is this gland has got such a larger size that it compresses the trachea, and they have a problem to sleep. So the quality of life is majorly compromised in patients of anaplastic thyroid carcinomas. So I could not get a picture from the Indian data, but in the Western setup picture, in which is a female, elderly female presenting with a large neck mass, and this is such a huge mass that it can invariably compress the trachea. Patient can present with hoarseness, dysphagia, and all other symptoms. So how to diagnose? History and clinical examination of the thyroid gland, as clinical examination explained by Chandrasekhar in previous presentation, is very important. Now we also have to go for a laboratory evaluation in patients with anaplastic thyroid carcinoma, and it should include a complete blood count, the basic metabolic profile of the patient, liver function, coagulation factors, and thyroid function test. Thyrotoxicosis, hypocalcemia, and leukocytosis have all been described in these patients, but they are not at all any relation to the prognostic factors and all. So additionally, anaplastic thyroid cancers occurs most commonly in patients who are very elderly, around 50 to 60 years of age. And some of these patients suffer from dysphagia and weight loss. So a thorough nutritional assessment, including a dietitian, is recommended. So how to diagnose this tumor? There's a role of radiology like ultrasonography. As we know, 40% of the patients have extrathyroidal extension at present and lymph node involvement, so it may be helpful to determine lymph node status and invasion. However, there are no specific USG features to ATC, which are specific in differentiated cancers, but they are not specific in anaplastic thyroid cancers. So cross-sectional imaging such as CT, MRI of the neck and chest should be obtained prior to surgery to assess the extent of tumor and degree of invasion of adjacent structures. Now comes a question about the role of CT, MRI or role of FDG PET. So the role of FDG PET has been established in ATC in this study done by the Poison et al., in which they showed that they took around 20 patients to stage the disease if there is any metastatic disease elsewhere apart from the normal location of the gland, in which they showed that there were 256 lesions in the body of the 20 patients, which were picked clearly by the PET scan, but could not be picked by the CT scan. And what was the gold standard? The gold standard was they followed the patient on a regular basis after 3 months with a PET scan, and the lesions which had decreased FDG PET activity. In those patients, there were around 8 patients who had no FDG PET activity, and they had overall good survival as compared to the patients who had FDG PET activity, and after 2 to 3 months, they recurrence occurred and they passed away. So FDG PET has a role in establishing the distant metastasis, which can never be picked by a PET scan in most of the times, not always. As per ATA guidelines, the initial American Thyroid Association guidelines, the initial imaging should include a neck ultrasound, cross-sectional imaging of the neck, chest, imaging of the brain, and FDG PET to stage the disease. As anaplastic thyroid carcinoma, metastasis can virtually arise anywhere. Imaging of the entire body is necessary to correctly stage the patients. So this is a pictorial representation of the thyroid gland. Behind is a trachea, and behind trachea is esophagus. So this is a gland which is encompassing the esophagus, trachea originating from the right part of the right lateral of the thyroid gland, and it also encasing the carotid sheath, which has the internal carotid artery, jugular vein, and the vagus nerve. In this CT scan, if we see, there's a large tumor arising from the thyroid gland, which has replaced the central structures of the neck to the left side, encased the carotid sheath, and also posteriorly encased the esophagus. Now, if we see in the histopathology of anaplastic thyroid cancer, they do not resemble that this cell has been originated from a follicular which has been derived from thyroid. They are multiple giant cells with a pale eosinophilic cytoplasm, and there is a tumor after treatment. There is a trachea. The carotid sheath has been relieved, and the esophagus, which was involved initially, has also been relieved. So I'll discuss the management later on. Now, staging. As per the AGCC 8th edition, all the anaplastic thyroid carcinoma are stage 4 disease. And if it is limited only to the thyroid, we'll call it a 4A disease, and it will always have a good prognosis. So if there is any T4A, any N, but M0, no metastasis. In 4B disease, the tumor involves extrathyroidal extension, means it can take away the carotid sheath, it can eat up the esophagus and go beyond. So T4B with any N but no metastasis. In 4C, we see the metastatic disease, which is M1. So the most common metastasis in anaplastic thyroid cancers are the most common site of metastasis. It's the lung, then bone, and then the brain. So this is a data I've picked up from Mayo Clinic, because Mayo Clinic has a lot of experience in treating anaplastic thyroid cancer from last 80 years, in which the patient, you see at presentation, if there is 4A, then the median survival is around 5 months. If it is 4B and 4C, then the median survival is very, very, very less. And I'll also take this picture later on when I'll combine the treatment modalities, and then I will show that how the graph is going when we offer some treatment to the patient and how they respond. Now, this pulls together a lot of studies which tells that there are some prognostic factors associated with anaplastic thyroid cancers, but at the same time, some papers say no, these are not very well established prognostic factors. So let me sort of take you to a view of all the papers which are published in the ATA guidelines. So if we talk about the age, which is a prognostic factor, if we talk about the differentiated thyroid cancers, but in anaplastic, they don't have any role. So the 9 papers tell yes, age is a prognostic factor. Same time, 8 papers say no, it is not a prognostic factor. Gender has no role. It's not like male will survive more than the female. It's not a scenario. Tumor size is not a scenario. But if you see surgery extent, 17 papers say yes and 4 papers say no. So surgery is invariably a large thing which can tell you that it is a prognostic factor. For example, if a patient has underwent a R1 resection, then it is very clearly evident from studies also, although the quality of evidence is not very great, it is very clearly evident that they will survive more than the patient who have underwent R2 resection. Radiotherapy, it is also an established role. Quality of evidence is moderate, that it is a prognostic factor. Distant metastasis. So these 3 things take a toll over others. So they can be taken like, yeah, it can be a prognostic factor, but the role is not well established because the quality of evidence is not very good. If you talk about the combination therapy, so these are our previous paper which tell you yes, combination therapy is not a prognostic factor. 5 papers say yes, 11 say no. But recently, due to, if we talk about the aggressive approaches, including IMRT, chemosensitizing agents, now they tell, yeah, combination therapy has a good survival benefit, but with very aggressive approaches if we talk about. But previous papers, they have ignored completely if combination therapy has any role. So if I talk about the cause-specific mortality rate, then you can see this graph in which a papillary thyroid cancer, after 25 years of initial treatment, 5% of the patients will die. 5 of the patients will die. And in this Hurther cell and follicular, it is higher. But you see, if ATC in the anaplastic thyroid cancer, it takes a toll over all other differentiated cancers. In 1 to 2 years, 90% of the people will not be there. So that was the reason, the rarity of this tumor and so much of aggressiveness, that we don't have very good trials to prove our points. So what are the staging distribution? At what stage the patient can present to you? So these are all the papers in which particular number of patients, whatever they have included, I have written here. And in this all the papers you can see patient presenting with only 4A disease, in which the tumor is limited to the thyroid, is very, very, very less, around 20%. In 4B and 4C, it is 40 to 60%. So this paper by Akashi, which is recent, it is clearly showing that 58% of patients or 60% patients will present with metastatic disease, and 4B and 4A patients are very, very, very less, 10% to 35%. So if now comes the management part. So if we talk about the management of ATCs, the management of anaplastic thyroid cancers involve the multidisciplinary approach. Means we have to include an endocrinologist, a surgeon, a radiation oncologist, medical oncologist, and palliative care physician role is very, very, very essential. The first step in management is to assess the resectability. For example, if a patient is presenting to you in the clinical setting with a large neck mass and you have diagnosed, it is anaplastic thyroid cancers, then the first step, you should always see that whether it is resectable or not resectable, which you can get from different radiological scans. I've told CT, MRI. For patients with loco-regional disease and in whom a grossly negative margin is achievable, initial appropriate management includes surgical resection. So it's a rule of the thumb. If the disease is 4A and in some cases 4B, and if it's the expertise of the surgeon that he can grossly resect the disease, then the survival is much, much more than if it is only a debulking surgery. So if a grossly negative margin can be attained, then the first thing should be done is surgery. What type of surgery now I'll discuss. In circumstances when the disease is considered unresectable or high risk, neoadjuvant radiation or chemotherapy can be considered, permitting delay primary resection if needed. Adjuvant therapy with radiation, with or without chemotherapy, should be considered in patients with both resectable and unresectable disease. So surgery. So it's a cardinal rule that surgery has to be explored in two. If a patient has to be surgically planned, then the two cardinal rules which you have to take care. First is the assessment of the airway, and in second setting you have to go for an expeditious treatment. So maintaining airway and securing a patent airway in patients with anaplastic thyroid cancers, because invariably the trachea can be involved, can be challenging because routine tracheostomy is not recommended and does not prolong survival and is best avoided unless there is an impending airway compromise. So recommendations for tracheostomy, they are clear-cut recommendation. If the patient has acute airway distress, you should go for a tracheostomy. And if if this unresectable tumor that would benefit from debulking, you should go for a tracheostomy. But tracheostomy should never be done in an urgent or emergency setting, because you may need to explore whole of the neck and then do it. So experienced surgeon should be involved, and it should only be done in an operative room setting. So after tracheostomy and its indication, if the loco-regional disease is present, so after tracheostomy, if a loco-regional disease is present and a grossly negative margin, R1 can be achieved, surgical resection should be done. The quality of evidence I'll tell in next slide. In patient with systemic disease, resection of the primary tumor for palliation should be considered. For example, if there is a metastatic disease and a surgeon is saying, go home, I cannot operate, then that's not the cause. It tells that even if you could do a R2 resection or a palliative resection, so that the patient can breathe and the airway can be secured, that should be done. It should not be that it's a metastatic disease. There's no need of operation. It is also evidence I'll show in next slide. So for intrathyroidal tumors, a total thyroidectomy with a therapeutic central and lateral neck node dissection is recommended. And in 4B tumors, the above recommendation is also applied, although the neoadjuvant preoperative radiotherapy can sometimes be considered in order to downstage the locally unresectable disease and subsequently enable gross total resection, that is a primary delayed resection after radiotherapy. So the extent of surgical resection, why I'm telling that R1, R0 resections are important. So these are the papers which clearly show that the 3-year survival is 50% versus 4% with R0 versus R1, R2 resection. And if I talk about the paper of PRA, it has told that if do a R1 resection, then the possibility of survival is at 6 months, it was 92. Actually, in this paper, they included 44 patients, 67 patients, out of which 44 patients could undergo surgery, in which around 14 patients could undergo a R1 resection and other patients could only undergo a debulking surgery. So at 6 months, the survival was 92%. At 1 year, it was 92%. And at 3 years after R1 resection, it was 83%. As compared to patients who only underwent debulking surgery, at 6 months, the survival was 35. At 6 months, it was 53%. At 1 year, it was 35%. And no patient could be alive after 3 years. So it clearly tells us that R1 resection is beneficial for patient. If grossly negative margin can be attained, patient should undergo surgery on the upfront basis. So what is the role of delayed primary resection? For example, if a patient is coming and a surgeon is saying, I cannot operate right now. So the thing is, some neoadjuvant form of treatment can be given, and its evidence is, there was a study by Higashiyama et al. In 2010, in which what they did, they took 9 patients who were initially not amenable to surgery. And what they did later on is, they give induction paclitaxel at 80 mg per meter square for day 1, 8, 15. And after this, 4 of the 9 patients could attain a grossly curative surgery. Although the patient number is not high, but these are very small studies which can light up and tell us that these things can be done if a patient is non-operable initially. And then they underwent adjuvant RT in a dose of 54 to 60 gray. And you can clearly see that these 4 patients are alive at 32, 33, 15 and 11 months. So this clearly, not very clearly, but this tells us that a delayed primary resection can be done after giving some neoadjuvant form of treatment. And there's a paper by Basic and et al. I could not trace this paper online, but it showed that pre-op chemo plus RT improved survival in 12 patients initially who were unresectable. So the role of neoadjuvant therapy in patients who cannot undergo curative resection on the upfront basis can be done. So after this, what is the adjuvant treatment strategy? What if after surgery, what should be done? So in patients with anaplastic thyroid cancer, the benefit of systemic chemotherapy and radiotherapy is unclear, but may be considered in 3 clinical settings. For example, as neoadjuvant therapy for locoregional ATC to downstage tumor, in which the 2 studies I showed you right now. And after that, as adjuvant therapy after complete resection, or at last patient who can never undergo surgery, metastatic disease, as palliative therapy. Adjuvant therapy in the form of radiotherapy or chemotherapy should be started as soon as the surgery is completed, usually within 2 to 3 weeks after surgery. These are clear-cut ATA guidelines. Some, but not all, retrospective studies suggest that multimodal therapy with a combination of surgery, R0 or R1, and definitive radiotherapy with or without chemo achieves better survival rates. Even with patients who have R2 resections or unresected disease and have good performance status, they should be offered radiation because this may result in better disease control. So what is the simulation and field design? This has already been covered by Shailendra Bose. I'll just touch up once. So the patients are simulated in CT scan by CT scanner in supine position with neck gently extended, shoulders down, and immobilized with thermoplastic head and shoulder mask. And what are the target volumes in anaplastic thyroid cancer which you want to radiate is, you have to always radiate the gross disease, and in cases of surgery, the post-surgical bed, the tracheoesophageal groove, bilateral nodal levels 2 to 6, upper mediastinum, tracheostomy site if present. Because the tracheostoma because the tumor doubling time is so high that it can also accompany the tracheostoma at times. May include level 1 or retropharyngeal nodes if present. So in patient with good KPS without metastasis, either standard fractionation 1.8 to 2 gray fractions 5 days a week, or since the tumor doubling time is high, so there are postulates about the accelerated hyperfractionation therapy 1.5 gray twice a day, 5 days a week. Schedules may be used, and in this all doses are around 54 to 60 gray. For palliation, shorter course may be considered, for example 3 gray in 10 fraction over 2 weeks or 20 gray in 5 fraction with option of second course after 2 to 4 weeks later. So what are the role of radiotherapy in R2 disease? For example, if a patient has undergone a primary debulking surgery, then what is the role of radiotherapy? So the paper by Levendak if we give a dose of around 30 gray to the patients who have received a debulking surgery as compared to patients who were not resected, then there is an advantage of 3.3 months plus over the unresected disease. In the paper by PRA, when he increased the dose, the 1-year survival in R2 resection was 54% versus 17% in patient who did not underwent surgery and only received radiotherapy. So it is showing that the more you increase the dose, the more tumor you can take away with radiotherapy and it can improve survival. So the graph I showed you initially, that 4A, the survival was around 5 to 6 months. So there's a so this in patients in the Western setup, when they are aggressively managed, if we give IMRT plus radiosensitizing and adjuvant chemo after surgery, the survival at 5 years was around 55%. But at the same time, this doesn't look promising. In this, they only included 10 patients, and those patients, they had good KPS and they had good performance status. So this was the result after aggressive approach. So what is the role of conformal radiotherapy in anaplastic thyroid cancer? The paper published which tells us that patients of anaplastic thyroid carcinoma were treated with 3D CRT and intensely modulated radiotherapy. So in this 53 patients were analyzed, 31, around 58% patients were irradiated with a radical intent. Median radiation dose was 58 gray. 13 means 25% of the patient received IMRT to a dose of 50 gray, and 39 patient received chemotherapy with radiation. So if we see that their Kaplan-Meier survival, the 1 year for definitive irradiated patients was 29%, and patient without distant metastasis who have received 50 gray had superior survivals. So if we increase the dose, then there is clear-cut benefit with survival. 5 such patients had no evidence of disease on last follow-up, and use of IMRT versus 3D-RT did not influence toxicity. So the outcomes of anaplastic thyroid cancer who are treated with 3D CRT or IMRT remain equivalent to historical results. So what are the chemotherapy regimens available? So in the Western setup, they always use a doublet. They have a particular protocol, I'll tell it. They use a doublet in the form of paclitaxel, docetaxel, doxorubicin with growth factors, and docetaxel and doxorubicin alone. But in our scenario, as the patient KPS is not good, we use single agents like paclitaxel, cisplatin. But their main role is only radiosensitizing. They are not used particularly on its own. They are always combined with radiotherapy.
I think doublets are mostly given in adjuvant setting.
Doublets are given, ma'am, in adjuvant setting. Doublets are given. Pre and post RT, they are given, ma'am. So in patient with non-metastatic disease and good performance status, cytotoxic chemotherapy should be added to radiotherapy. These are only recommendations. They are not, quality of evidence is very, very, very low. In the past, doxorubicin has been used most often. However, more recent drugs, cisplatin and paclitaxel, have been used as radiosensitizing agents, and studies of these drugs have reported better 1-year survival rates as compared to the historical controls. So in case of advanced metastatic disease, no cytotoxic or targeted systemic therapy has shown to have curative potential or to prolong the survival rates. So in metastatic disease, the main role comes is the palliative therapy which we can give to those patients. So therefore, patients' disease status, performance status should be considered always before choosing the best approach, as most therapies have risks and side effects. So if I talk about the protocol which is now widely used in the Western setup, but it is very, very, very aggressive approach, this is called as INSTITUT GUSTAVE ROUSSY protocol for anaplastic thyroid cancer, developed by an institute in France. So what they do is they, after total thyroidectomy and central lymph node dissection, when feasible, mostly R1 patient, after the gross total resection, they combine 2 cycles of doxorubicin, 60 mg per meter square, and cisplatin, 100 mg per meter square, 3 weekly. And what they do, they give 2 cycles after surgery, prior to radiotherapy, and then they go for a hyperfractionated radiotherapy, doses around 54 gray, to neck and upper mediastinum. And post radiotherapy, they again give 4 cycles of chemotherapy. So total 6 cycles. And what are the results is, 35 patients received 3-phase combined treatment, which was published in the BMC Cancer. Complete response was seen in 14 patients, which is around 31.8%, 32%. Partial response was seen in 18% of the patient, and 50% has progressive disease. So these results, although the data is very less, can tell, yeah, it can have a survival, but at the same time had a progressive disease also. So the role of chemotherapy and aggressive approaches is not well established. And the median survival of entire population was 8 months. So now let's come to the novel therapies, the mutations which I showed you in the initial slides. So what are the role? So molecular targeted therapy trials in anaplastic thyroid cancer have been conducted under the basket protocol designs and have been largely targeting the BRAF mutation. Because in patients of anaplastic thyroid cancer, the BRAF mutation is around 30 to 33%. Other mutations, yes, they are there, like as PIK3CA, HRAS and ALK are also available, but are very rare, around 13%, 4% and 1.5% respectively. So the most of the trials, what they have targeted the BRAF mutations. Although the pace of progress towards developing targeted agents for ATC is slow, there has been lately been some promise recently. So what are the targeted therapies? So this is a particular menu in which it can also be used for differentiated cancer, like as imatinib, which is platelet-derived growth factor receptor, geftinib, sorafenib for VEGFR. Lenvatinib, it is used for differentiated cancers, has also been used for anaplastic thyroid cancers, which a particular result is there, I'll show it. Vemurafenib, everolimus for mTOR pathway. Crizotinib has also been used in anaplastic thyroid cancer. Around 1% of the patients have ALK mutations, and 1 to 2 patients in the Western setup, they have used crizotinib, and after 9 months, there is no disease progression in those patients. And there is a drug called as fosbritabulin, which is combined with paclitaxel, which is also a microtubule inhibitor, and efgartigimod. There is a menu which of the drugs we can use. So first talk about the BRAF directed therapy. So the case reports of patients with anaplastic thyroid cancers who responded to selective BRAF inhibitors have led to enthusiasm for testing in clinical trials. So 2 basket trials have completed enrollment, of which one has reported the results. So if you talk about single agent, vemurafenib was tested in a small cohort of 7 patients. 1 had complete response, 1 had partial, 4 had progressive disease, and 1 was not evaluable. An other basket trial which is ongoing and they are enrolling the patient. So the role of BRAF directed therapy is not well established because only 1 patient had complete response out of 7 patients. Now if we talk about after BRAF multi-kinase inhibitors, sorafenib has no role. In a phase 2 trial of sorafenib in anaplastic thyroid cancer in 10 patients, no objective response was seen and median OS was 5.4 months. 2 additional trials documented no response with 6 patients enrolled. So sorafenib has no role. There is a study on lenvatinib which is being used. So Takahashi et al. Reported a phase 2 trial using lenvatinib, which is a small molecule vascular endothelial growth factor inhibitor. In anaplastic group, only 11 patients were enrolled. This lenvatinib was also used in differentiated thyroid, but in ATC anaplastic, they could take 11 patients. And results were 3 had partial response, 7 had stable disease, and only 1 patient had disease progression. And median overall survival was 10.6 months, and median progression-free survival was 7.4 months. So this is being used for differentiated cancer and also being used now for lenvatinib is used for anaplastic also by some surgeons especially. So this lenvatinib is currently approved for differentiated thyroid cancers in the Western setup in US, but is approved for all subtypes in Japan. A phase 2 trial of fosbritabulin in advanced anaplastic thyroid carcinomas. So fosbritabulin has an action mechanism of action similarly to paclitaxel. So initially 26 patients received fosbritabulin at this dose and as a 10-minute intravenous infusion on day 1, 8, 15 of a 28-day cycle. Result was fosbritabulin was well tolerated. Grade 3 toxicity was observed in 9 patients. Grade 4 in 1 patient, and the main side effect is QTc prolongation. The median survival was 4.7 months with 34% and 23% alive at 6 and 12 months respectively. Why I'm telling this? Because this is the largest trial ever done on anaplastic thyroid cancer till 2009. So the conclusion was there was no objective response seen with single agent fosbritabulin as administered in this trial and did not observe a doubling survival as a primary endpoint. The primary endpoint was to see if there is a doubling of the survival, but they could not achieve it. Now, after that, there was a randomized safety and efficacy study of fosbritabulin combined with pacli and carbo against anaplastic thyroid carcinoma. This study got closed because the plan was around 180 patient accrual, but very low accrual. The study was closed, but they could then also visualize around 80 patients were assigned. So the median OS was 5.2 months and 1 year survival for this carboplatin and carboplatin paclitaxel and fosbritabulin versus carboplatin pacli was 26% versus 9% respectively. So better in the pacli carbo and fosbritabulin arm. There was no significant difference in progression-free survival between the 2 arms. Grade 1 to hypertension, grade 3-4 neutropenia were more common in the CP and fosbritabulin arm because it will obviously become more toxic. There were no significant adverse cardiovascular side effects. So what comes next is we have seen the role of radiotherapy, surgery, chemotherapy, targeted therapy. Now what is the role of palliation? So the patient with metastatic anaplastic thyroid cancers almost uniformly have short survival, we know, and no prospects for curative outcomes, especially in 4C disease. Moreover, use of aggressive approaches in metastatic anaplastic thyroids has never been definitely shown to improve survival. Palliation of symptoms and or imminently threatening lesions should be given high priority in comparison to treatment with systemic therapy. So pain management should be done, tracheostomy to relieve tracheal compression and breathing, tracheostomy to be done always in operative setup rather than emergency unless it's urgent. Bisphosphonate therapy as patient can present with bone meds, angiotube for adequate feeding access, and counseling the patient and attendant is always advised, and a psychosocial support is also advised. So tracheostomy on the last slide. For patients who plan to undergo palliative radiation therapy but who have airway compromise, tracheostomy should be done before initiation of radiotherapy, as progression of airway symptoms could exacerbate during radiotherapy. As a result of substantial technical difficulties with tracheostomy in patients with large neck malignancies, these tracheostomies should generally be undertaken in a tertiary referral center. So it is important that patients have a realistic expectation of potential significant problems with tracheostomy, like he won't be able to speak, there can be aspiration. So these are all things. So we are done with palliative part. So I'm done. Thank you.